So welcome all again. So I would like to discuss few aspects of ECG when you encounter an emergency. So this is case 1, a 19-year-old male patient came with complaints of chest pain, which was central heaviness since one day, which was waxing and waning. History also suggested he had hypertension and was not on any medication. So this was the presentation ECG outside 8:51 AM. He was treated outside and was given some medication which were not available. So this is the ECG which we have, which was done outside at 8:50. So what do we see here?
Rajshekar, you want to comment the ECG?
So this is a 19-year-old male patient, sir, who came with chest pain.
That's a classical dilemma for anybody, I think, especially if a patient like this goes to a general practitioner or a MD physician. Young person, 19-year-old, nobody will suspect a cardiac problem, I think, with a chest pain that ongoing, off and on.
Yes, sir.
So ECG also, some subtle changes are there, which how many of the general practitioners or physicians will be able to pick up. And what about?
Yes, sir.
I would say first of all, because considering the age of the patient, the index of suspicion is less. However, patient has chest pain and there are no florid signs of acute coronary syndrome in this patient. But however, few suggestions are given. One is to go for repeat ECG after some time, maybe 5 minutes, 10 minutes, 15 minutes. And second is to go for special leads like V7, V8, V9 to look for changes. Many a time what happens is, even though the pain is characteristic, because the involved arteries are not the classical ones, sometimes obtuse marginals or diagonals, sometimes the changes may not be present. Other thing is that sometimes always ECG needs to be compared with the previous ECG, and here we do not have an ECG for comparison. So unless we have one, we cannot see. But however, nowadays the biomarkers are available. Some of the biomarkers rise very early. I think we have to interpret all three together. One is the chest pain, and second is the ECG, and third is the biomarker. All three we should take together to interpret. So any patient who has chest pain, we need to take it seriously, and we should admit him in the EMD and observe him and take serial ECGs and biomarkers.
Yes, sir. So actually he came to us. So these are what is the next steps, as sir has discussed just now. A repeat ECG TROP-T should have been done in this patient. I will try to get some details from this ECG. So if we carefully see, there are some kind of early repolarization bar STT changes in one AVL. You can see there is definite ST depressions in lead 3 and V4, and the T wave appears slightly tall compared to the R in V2 and V3. So these are only subtle changes which we had in the morning. Actually, he came to our hospital in the evening with this ECG. There was a dramatic change in the ECG at presentation. The pain was waxing and waning, so he came when he had a pain. So this time you can see that there are significant changes in the ECG. Ideally, the ECG should have been repeated and he should have been kept for observation. But unfortunately, because of the young age and subtle changes, probably it has not been picked up during the first, but definitely there have been enough changes. You can see a drop is elevated 9430 with RWM in the LAD territory. So in this ECG we can see that the T wave has become more prominent. There is poor R wave progression. The ST elevation in AVL appears much prominent. And so eventually what happened is this patient had an LAD cutoff. So even though he was 19-year-old, strong positive drop change in ECG, we went for an angiogram early and we found that the LAD has totally blocked and we had to stent it. Second case, 51-year-old male patient who is hypertensive, came with complaints of chest pain, aching type, retrosternal, epigastric pain. You should always remember the type of pain which is described by the patient, which I will mention in a while, at home, which lasted for only half an hour. So he had pain at home for half an hour, then he came to our hospital. He does not in the ER. So this is the ER ECG. So what is the next step and how we should proceed with this? He definitely had a typical.
Can somebody please adjust the audio? Is not your audio is not audible this side. Earlier, first case.
Is it audible?
Yeah, now it has come. Yeah. Okay.
So
thank you.
a 51-year-old hypertensive
I got
comes with a, he had half an hour chest pain at home and now he comes to our hospital without any pain, and this is the ECG which fairly looks normal, and we tried to calculate the heart score in this patient with the help of troponin, and the risk is intermediate. Now what to do? So what are our options now?
You want to tell anything, sir?
Patient came with the typical angina, but heart score is intermediate and ECG is normal. So what is the next line of management?
So depending on the heart risk score, this is the basic thing. One is the history.
Yes,
it is
sir.
very classic. Then
True,
there is
sir.
no doubt. Otherwise, in doubtful cases, for all the other audience, if this scoring system you be familiar with, based on this we can take the further decisions and carry forward.
True, sir. We actually observed him for some time. Then we have taken him from angio. So we found there is a proximal LAD very tight lesion which was thrombus containing. So to summarize, I would like to highlight few things in my presentation. So always consider few things whenever a patient stays that I am having this type of pain, that type of pain. Always try to get the descriptive term from the patient. So if it is central, squeezing, gripping, heavy, tight, as a patient mentions, then it is high possibility of ischemia. And towards the green side, sharp, fleeting, shifting, pleuritic or positional, the chances are very less. And sometimes the chest pain radiation is also towards the right, sometimes both the arms. So I have mentioned few likelihood ratios which are there on the right side of the chart. So you should always try to get the descriptive term of the patient. So as sir has told, so what should we do when a patient presents with us? First thing, assess symptoms which I have told you, try to fit him in the description, what he is having. Based on that you will get whether it is highly descriptive, medium or low. Then you go for an ECG, then you go, if it is non-diagnostic, then we can go for troponin test. So there are few ECGs where the interpretation of STEMI becomes difficult. The first is LBBP, ventricular paced rhythm, LBH, early repolarization pattern, and acute pericarditis. In these findings, whenever these are there, then the ECG is difficult to interpret. So what do we have? Now what to do? So whenever you find an non-diagnostic ECG, we should always do a posterior lead, V7 to V9, which is a class 2 indication. So we place the leads behind the chest here. So this is a posterior wall MI, very evident, and if you do on the right side, you can see there are ST elevations in the posterior leads. The second point, always search for reciprocal changes. If you carefully see in the first case, there were definitely reciprocal changes in one AVL, Next is AVR lead should be carefully washed. You should always do a serial ECG. You should have done TROP-T and TROP-I at the first presentation and later. So this is the AVR elevation which we can see, and there are slight depressions all over the leads, which is suggestive of triple vessel with left main. So whenever in the first ECG, I would like to mention there is slight problem with the ST elevation 1 AVL. There are 3 differentials for the elevation of such a type. I would like to mention STEMI, acute pericarditis, and benign early repolarization pattern. I will try to discuss few things. So this is the shape of ECG pattern when there is STEMI, convex up. These two are concave, acute pericarditis and BER. So in acute pericarditis, the radiation is towards the trapezius ridge. That is to be remembered. The most important thing in acute pericarditis and benign early repolarization pattern is ST to T wave ratio. If it is high, then it is suggestive of acute. If it is low, it is suggestive of repolarization pattern. There is one more sign called sporadic sign, which is ST elevation with slight downward sloping in the TP segment. The fish hook pattern or the slurring or notching in one AVL is suggestive of benign early repolarization pattern. These were the close differentials in that patient. So next test is TROP-I. I would like to briefly discuss few things about TROP-I. So what happened to CKMB in all these guidelines? It has become class 3. There is no use of CKMB now. So in general, what happens is the TROPS I and T starts leaking from the cardiac muscle when there is an injury. So it starts rising from 2 to 3 hours and starts peaking at 24 to 48 hours. So we should be able to detect the TROP-T as early as it is released into the body. So that is the important task. So we have 5 generations of TROP-T, and the latest generation is called high sensitive TROP-T. Please check in your lab whether you are using high sensitive TROP-T or not. So the high sensitive TROP-T has 2 points. The first point is very low limit of detection, means small rise of TROP-T also it should be able to pick up. The second point is low coefficient of variation. That means if you do the sample at the same point of time, it will give you the same result. That is the most important thing. And it is the variance between the tests is less than 10%. A high sensitive TROP-T should do the following things. It should detect the TROP at a very low limit, as well as the variation should be less than 10%. Then it is suggestive of high sensitive TROP-T. If you see the left side chart, the normal green levels followed by yellow. Once the TROP starts rising, a conventional TROP-T can be only recognized. Conventional TROP, if you are using, it can only detect from the red point. While in between, even though the TROP is there, the conventional TROPs do not detect the TROP. So that is what HS TROP-T does. If we are using the 2 commonly things which we use in peripheral setup is sensitive TROP-T, which is visual aid. The cutoff value is 100 nanogram per L. If you are using a POC, it is 40 to 200, 2000. And if you are using a high sensitive TROP-T, it is 14 nanogram per liter. That means for a liter, it can detect 14 nanograms. That is the sensitivity of troponin. So why is HS TROP-T important? For each minute or each hour wasted, there is a lot of myocardial damage and it will lead to high MACE in the future events. So brief things about TROP-T and TROP-I. What is the difference? TROP-T is seen in skeletal and heart muscles, while TROP-I is only seen in exclusive heart. TROP-T rises more in renal failure. Comparing to assays, both are good enough. There is no difference between TROP-T and TROP-I while selecting the patient. There is a concept called true positive and true false positive. What is true positive? In these cases, the troponin rises, but there is no evidence of any coronary artery disease. Actually, troponin rises in these cases. There are few things which will disturb the assay. The test which you are doing, there are few things in the blood which will cause a positivity in the assessment of troponin. This is called as true false positive, because these all factors will interfere with the checking of TROP-T in the sample. That is more important. The true positive means troponin is definitely raised in those conditions which are being picked up, while true false positive means because of all these factors it will interfere with the assay. This is called as true false positive. So based on this, this led to development of what is called as rule in and rule out algorithm. So you do a high sensitive TROP-T at 0 and 1 hour, or 0 at 2 hours, or 0 at 3 hours. So we can understand why high sensitivity is done within 1 hour. That means it should be able to pick up very small quantities of troponin. So that is the time frame which we can do it. So within 0 and 1 hour, even the small amount of rise will be picked up by the high troponin assay only. So based on that, we have designed something called as rule-in and rule-out test. Okay, so once the drop becomes positive or there is a change in troponin, then it goes to rule-in. That means the patient definitely has an acute coronary syndrome and we have to look into it seriously. So the take-home points I would like to mention: 15 to 25% of the chest pain in ER are cardiac in origin. At least 2% ACS are missed. MI in young age should not be missed. At this point of time after COVID, definitely should not be missed. We have done pretty good amount of cases in our lab recently. From 30 to 35 years, or at least 10 patients in last 2 to 3 weeks. In 50% of the MIs, remember that the initial ECG is often non-diagnostic. When ECG is non-diagnostic, always repeat and do troponin. When you're doing troponin, always do high sensitive and watch for the change in troponin. Thank you.
Yes, sir. Any comments, sir, from panel?
That was excellent. Two cases, very illustrative and learning for everybody. The lessons are there in that. First case, young patient, nobody will suspect he would be having heart problem, but that ECG, if somebody could see, it is not like early repolarization. You cannot just push it off because some reciprocal changes like thing were there. Suppose somebody had detected, suspected that, I think that much delay would not have been there. Or next step would have been to keep the patient, do the trop T or trop I, and then pass it on. Or at the most, you can refer for ruling out immediately. There was a big gap in that. Obviously, time he would have lost. Second case, almost normal ECG, but classic history if it is there. Avinash, in the second case, why did you take him up for direct angio? You said borderline, it was intermediate risk score told. And then you kept him for observation, you told, and then took him up
Yes,
for
sir.
angio.
We did not plan for emergency CAG, but we had to plan. The index of suspicion was very high. Actually, in risk factor heart score, if you see obesity, hypertension, dyslipidemia, lot of factors will come into picture. But an old patient, 51-year-olds, maybe we should individualize sometimes the decisions. We should not always follow the guidelines. I felt the chest pain, the amount of intensity and the problem he has given, I thought with individually we should also take care of the patient. Instead of he is fitting into only this criteria, we should not always believe that. So I try to individualize the patient in that way. So emergency I didn't take it, but definitely I planned for the procedure on the first basis.
Yeah, that's it. So whenever in doubt, please don't hesitate to refer, if you know, or if you can manage and decide when to send it. Timing is very important. Dr. Ashekar, you want to take that?
In these type of cases where the suspicion, clinical suspicion is very high, but ECG is not contributory. So we have been saying that we will observe and then we will repeat ECGs and biomarkers. But then it's a golden hour, and nowadays we are talking even about platinum minutes. So in such situation, when suspicion is very high, maybe it is an option to go for a triple rule out, like emergency CT angiogram is done. So here some other differential may also be there. I think it is a good idea to do triple rule out. If that is not available, if the suspicion is very high, there is nothing wrong in doing an emergency angiogram.
Over time.
Yeah. Thank you, sir. Thank you, Avinash, for a nice presentation. So now I call upon Dr. Ramesh Babu, sir, for his talk. Sir, Narasimhan, sir, please come to the place for as a moderator. Sriman Narayana, sir, as well.
Respected moderators and panelists and the august audience, at the outset again I would like to express my sincere gratitude from the bottom of my heart for the time you are taking on a Sunday to sit from morning to evening with some change in the program and everything, and with some sound issues and all. you have been very patient, and I again thank all my friends who worked with us, who came from Coimbatore, Vellore, all these places. So I'm thankful to you again. So the topic I'm going to present is very close to my heart. Certain innovations or scientific evidences, when these are published in a journal or presented in a conference, which are against the norms, which are not the usual kind of practice, then it will definitely evoke a lot of debate, doubt, confusion and all. I'll try to see show you in the next 10-15 minutes what I have been practicing in the past almost 35 years. What were my impressions when I was in All India Institute as a DM student, and after starting practice, what I have observed. When I started practice, there was nothing here, no cath lab, and not even a ventilator. It pains me now if I think these patients would have been saved just with PCI or ventilator or something. So many patients I lost, in fact, in the initial, where I could not do much in cardiogenic shocks, likewise. So what is really happening in the practice of cardiovascular disease in this area, and how we can bring in some thought process, change in the thought process, and with the change in the guidelines which are taking place. Fortunately, after long debate, confusion and all, now things seem to be settling, which I'll be talking to you, how it translates into therapeutics, societal benefit and saving of young Indians. I shall tell you that, when I was a first year DM student, I was given treadmill posting, right? So treadmill, when I was doing, my only vision was, is it positive or negative? So when it is negative, I was feeling very happy and I was used to pat, everything is fine, right? So that was the knowledge. And if it is positive, I was telling, no, you have disease. Now you know that both are wrong. Both can be wrong. Most of the time they are wrong. And then before I left All India Institute, there was an echocardiogram. Dr. Srivastav, then Dr. Nanda came from US and they showed the echocardiogram, and then we were very happy that we were seeing everything in the heart. So inside the heart we were able to see everything. So we thought we could make all types of diagnosis. And in fact it was a non-color Doppler initially. Color was introduced when I came out, after I came out. So, and then the other investigation which was there in All India Institute was angiogram, coronary angiogram. So that time, coronary angiogram showing, if a single vessel is showing some 60-70% stenosis, we think the patient is going to die. And there were many instances, Dr. Narasimhan would agree, we were advising surgery. For single vessel disease, we were advising surgery. So this is all the science at that time. We came out with that, and by giving streptokinase injection here, we used to think, oh, we are saving lives and we are doing a lot of good to the humanity and all. Yes, we were doing something, but then it was pricking. We are not doing the same things which can be done, which need to be done, which are being done in other places. So I was solely focusing on how to build up a cath lab and a CTVS wing. So to, gather the resources and the confidence and all, it took around 8 years. So in 1996, I started. Then as the years passed by, yes, I thought, okay, with cath lab and all, I can do better things and everything. I am understanding what is stenosis, what is angiogram, yes, I can read it better. Then as the days passed by, Now, I know that I know not. Right? So many cases, in other words, cardiovascular disease is an enigma. After seeing almost 90,000 coronary angiograms and almost 19,000 CT coronary angiograms and several types of patients, before entering the cath lab, a patient with treadmill test positivity and risk factors, if somebody asks me what is it the patient is going to have, if I say something, if I commit something, I am a fool. Let me tell you, most experienced cardiologist cannot predict what is happening in the coronaries, whether the patient is having a left main disease or a triple vessel disease, whether the disease is there in the branch vessels or distally, and how it is, how is the plaque, is there any positive remodeling. We can't tell with invasive angiogram what is it going to happen, even after the angiogram, what is it going to be the prognosis of this patient. So in other words, coronary artery disease is extremely unpredictable. You cannot predict with certainty in a good number of patients. A patient who is coming with a treadmill strongly positive, typical angina showing within 2 to 3 minutes, some downsloping 4-5 millimeters, yes, definitely patient will have some significant disease. But otherwise, majority of the treadmill positive patients with risk factors, we have seen risk factors, 3 risk factors, 4 risk factors, 65-year-old, we were thinking, oh, this man will have double, triple, or be ready with surgery or stent. Patient will have absolutely normal coronaries. Not once, many times. Dr. Prasad Rao sir is sitting here. He must have seen a number of patients. He must have read thousands of, angiograms. And this sort of uncertainty, unpredictability is the rule rather than the exception in coronary artery disease. So Dr. Krishnachand must have presented a physician who came from Karnataka, who has almost 35 years old experience as an MD, who was treating so many patients. His angiogram was normal 10 years ago. So he thought he was fine, he was going for walking and all. He came to Manthana Satyanarayana Raju's ashram to do some dieting and some, health and all. So he went for swimming and then he thought he is developing some chest pain. It worsened. He was immediately rushed and then he was having LAD block, almost cardiogenic shock, non-sustained VT, and then immediately within 30-40 minutes we opened the vessel, RBBB. So then there was a second vessel, 90%. We had to do it non-culprit vessel. Similarly, we have another national tennis champion who met me about 2 weeks back in Hyderabad. So this gentleman has been playing tennis, almost 50-year-old. So he was having some discomfort in the chest in the initial 2 to 3 minutes, and later he was able to play for 3 hours, 4 hours, and he became the national champion. But then he was not very comfortable. What is this happening? So some CT was done, and then risk factors and treadmill was showing some, borderline. Then he went, and then angio was done. It was showing mid-90% stenosis, and he was stented. Now he wants to go to Olympics. So he came to ask me whether can I go to Olympics with this stent and everything. So we do not know that 90% mid-LAD, whether walk through angina, whether he developed a lot of collaterals and what microcirculation, whether we have done right thing, they have done right thing or not, we do not know. Buzzword like microvascular disease, collaterals in a normal person, all of these are coming into picture now. These are becoming buzzwords. In other words, patients with 90% or even 2 vessels 100% blocks, we have seen many times patients moving around, nothing is happening, and they come and only 1 vessel is feeding, or they are the distal vessels. So likewise, so many variations, so many variances are there. And a number of studies which are done, RCTs, so many RCTs, controls were done. There is no other field in the medicine which is more confusing than the RCT trial data in the cardiovascular disease. This abciximab, a lot of thrombus aspiration, IABP, whatnot, there are ICU admission itself, there was controversy, debate, and lot of biases, segregation biases, confounding variables, a lot of things are there. And interpretation, then power of the study, debates, interpretation, negative, positive things. These confuse, mass effect, class effect, whatnot. We have seen several variations, and judging or jumping on a single RCT trial, ribavirin, likewise. So many confusing things. Biovascular scaffold, BVS 10, so much of hype. Where is it now? So these things confuse us. So we know that yes, we should not get confused whatever is the scientific data that is pouring in, and a clinical judgment with your experience and interpolating the data which is available, rather than jumping suddenly and starting something new because somebody has started and it has come up, is the crux. You have to be cautious. So this is what I am learning. Still I am in the learning process, and I will show you some of the cases they have shown, Krishna Chandra has shown. So this particular patient, right, he is moving around here only, is a close family friend also.
Display please.
So he is hypertensive, diabetic, with a strong family history of coronary artery disease. Massaging, brought to the patient, we took him to the cath lab, then Barua was there, Dr. Faruqi was there. So we have done a hybrid. We opened the LAD vessel, we took him to the theatre, and then we did bypass surgery. After the bypass surgery, 1998, around 15 years later or so, Dr. Narsimhan did CRT, Mr. Venkateshwara also. So he did CRT thrice, I think. So he did not die of coronary artery disease, he died of something else, right? Only about 1.5 years ago. So this sort of, his son, came to us with hypertension, with diabetes, sedentary, and lot of stress and all these things. So this was his, when before sending him CTC, I was suspecting that there would be some disease, 50%, 60%, or 1 or 2 vessels. But this is what it is. 2012, you see, it is almost normal. Then again, what is the timing I should repeat? He is hypertensive, diabetic, slightly obese. What is the timing I should do? As per the guidelines, it is somewhere around 3.7 years, right? One CTCA, next one with all these risk factors, 60-year-old. But then, he was not asymptomatic, we did not do. We did it in 2021, 9 years later. What does it show? More or less the same. So there is no progression of the disease, but as per the, literature, almost 20 to 25 score to percent increase in coronary artery calcium is there as per the MESA study and calcium consortium and all these things. But there is no increase. Whereas a person like that physician whose coronary angio was normal, he developed 100% block, which must have been there 90-80% long back, and another 90% block over a period of time. And another person, he is again smoker, diabetic, obese. So we did on 2013, and there was a mild lesion, 40%, something like that in different. Then he was telling, doctor, I trust you, you do the stent. Right? We did not do the stent, you don't need it. So, but he continued to smoke. And diabetes, obese, and businessman and stressful job. Again, nothing has happened. So why this is happening? And we have seen many patients, within 2 years, absolutely normal, within 2 years, or 30% lesion becoming 90% or 100%. So much of variability, person to person, genetic, ethnicity, whatever other risk, environmental factors, and so many other things which we do not know. Vulnerable blood, vulnerable thrombogenicity, what not, we don't know. So that is what coronary artery disease is. Now, in this ocean of uncertainty, what should we do? So we are hearing every day young patients dying, acute myocardial infarction, and in India, so many patients, Dr. Raja Ramesh presented 108 cases in COVID era, 100% block, and 108 patients primary, PCI done, and many patients he did aspiration. Thrombus aspiration now is not accepted, but definitely it is practiced by almost all interventional cardiologists, right, when it is the right thing to do. So nothing is certain, and medicine is an inexact science, not exact science. And that is the reason why you call sensitivity, specificity, positive, negative predictive value, hazard ratio, what all you are talking about. These are because it is not certain, it is not 100%. This is this, we cannot say. And another patient, the sister of the patient, the first patient, angiogram was done, in January 2018, right? Her father was in the hospital on the deathbed, and she was attending on him, and she complained of, she had some 3 to 4 days of some burning and chest discomfort which she did not tell. And she landed up in the night to us with pulmonary edema, cardiogenic shock. Then we took her and then saw that there is LED which was absolutely normal. It got 100% blocked. And there was we had to put IABP, we had to ventilate, and then she recovered. Similarly, we have another patient, again 75-year-old, similar person, absolutely normal, about a year back, again 100% block. So, with invasive angiogram, with CTCA, with CAC, with risk factor stratification, with compiling all these things and another 200 minor risk factors, all these things will not help us in an individual patient. In other words, should not treat the patient on the basal guidelines which are given only, but these are applicable for us to form an idea and how we should approach the patient. So personalized patient approach is the key, and there are several factors coming in, genetics and everything coming in here. So we have to learn continuously, we have to de-learn and then relearn, right? Now, what is it we have learned and what we are de-learning and what we are relearning? So, in this, as I told you in institute or when we started, our focus was only on the lesion. Whether 70% or 60% people used to fight, it is 50%, 80% because it will not give the accurate one, we know. It is not a 360 degree. So 2-3 angles we see, somebody says 50, somebody says 80, 70, because on the seniority, people used to believe, okay, he's a senior eye, so you should believe him. And then it was lesion focused. And then surgery was the only answer. PCI was not available. Just angioplasty was started by Dr. Manchanda at that time. So 1986 or so, 1987. And later, of course, PCI has come up. Now, between 200 and 215 stent, tubular vision, yes, if there is a critical lesion, stent will be better than surgery and all. And then there was never-ending debates with all these clinical trials between surgery and CABG versus PCI versus medical management. In all our conferences, national and international conferences, one person promotes for the same type of triple vessel disease, normal LV, mild LV dysfunction. Yes, one person argues it is for CABG, the other person for medical management, third one was for PCI, intervention. And at the end of the session, we were thoroughly confused. We thought all three are right, all three are wrong. So this is a usual trend which has happened for decades together, right? Almost 15, 20 years. And even then it continues. So what is happening? And people used to list out RCT trials, 1, 2, 3, 7, and then this trial, that analysis, this debate and all. And we know what is RCT trial now, with the limited variables and then segregation bias, interpretation bias and everything. With the RCT now, the artificial intelligence coming up with 735 variables analysis, at least things would be better. It has its own limitations, we know. Artificial intelligence has its own limitations. It can also be affected, influenced, right? But it will be better than your routine conductance of RCT trial. Power of the study is not, enough and all. So that is the reason why so much of confusion. Even for hypertension, more than 60,000 trials are conducted. So we never know what is the actual target of blood pressure, whether it is 120, 130, 140 or 150. But we know that 99% of the times blood pressure is not recorded correctly in the OPD. That all of us are sure. It has to be measured either at home or in the office, research blood pressure apparatus, or ambulatory blood pressure, which is better, but it has its own problems. So likewise, so much of debate, controversies we are living in the era, but that is good for betterment and future trials and better, evaluation. So from the lesion focused, and then second most important thing, we were thinking coronary angiogram was the gold standard, and then ischemia stress test is the gold standard. Even now many people believe, though it may not be entirely true, partially it may be true, ischemia stress testing was the basis for us to take a decision whether we have to go for a intervention or medical management. If it is at least moderately or severely positive, proximal disease, and doable surgery or doable PCI, you go for intervention. Otherwise, if it is diffuse disease, whatever it is, we have to do only medical management. Now, again, the other ischemia trial, Barry 2D trial, Courage trial, all these have shown that jumping to an intervention modality of therapeutic management based on moderate or severe positive ischemia stress test, either by treadmill or nuclear medicine perfusion or CMR or echocardiography, may not be absolutely true in all patients. Not that totally you have to rule out based on the ischemia guidelines only, you have to go ahead and all. So this is one test which has helped, but at the same time confused. And now in United States, Medicare says 50% of the ischemia stress tests are inappropriate, causing huge loss to the exchequer. And this ischemia stress test has to be used. Now the issue is whether you should use a treadmill or a nuclear perfusion test, whether before angiogram or after angiogram. Right? So there is a debate, and there is a reason for debate, and definitely we follow in certain people. So this is one thing based on 1990s, the report that 10%, more than 10% ischemia, they will fare better ASCVD events wise if you intervene. Otherwise, less than 10, don't intervene. Medical management is as good. But we know 10 or 15% or even 20%, the mechanism, pathophysiological mechanism of chronic coronary syndrome is different from acute coronary syndrome. The way you approach a patient with a chest pain in the emergency room is entirely different. With an unknown coronary artery disease is entirely different. From a person with a chronic coronary artery disease who comes with an acute MI again, he has, in fact, he has more chances of reaching a hospital rather than an acute MI patient, acute chest pain patient, just like your cine actor who died on the way with a ventricular fibrillation, with chest pain in the night, not a known cardiac disease. They are more likely to die on the way. That is the golden hour. Because in that 1 year, however small is the infarct, arrhythmic deaths are much more common because it is an unconditioned myocardium and there are no probably collaterals. And then we don't know microvascular disease and all, which is still a big enigma even now. That is the future, microvascular disease. So functional, structural, whatnot, everything. So now with this ischemia stress test and then risk factor stratification, which will come later, now the focus is not the only stenosis, it is the vulnerable plaque and the anatomic extent of the coronary artery disease, which is more important, which will tell you about the ASCVD events. Whether you do intervention, stent, probably bypass is better in certain conditions, LMCA, triple vessel disease, better than stents. And stenting is definitely useful in STEMI PCI, acute PCI. If you open the vessel within the first 40-45 minutes, nothing like it, and many patients will be saved and they will live the normal life. So this sort of lesion specific, and then we went for FFR. FFR, it has its own limitations. Doing is not easy, and for bends and then complications, dissections are more common. So for every patient you can't do FFR. And then visual, again you have to depend on visual estimate or some stress testing, again with its limitations. Now the issue is, instead of going for directly, aggressively for intervention and then only picking up the patients, focusing only on the patients who come to you with an acute coronary syndrome, cardiologists, physicians, state, public health, everybody should come together, and then we have to surge ahead to find the disease which is hidden, which is likely to cause problem in future, in the coming future, 3 years, 5 years, 10 years. Pick up, identify, advise, treat, and then when they have an acute problem, you can definitely direct earlier. They will also know that, yeah, I have a disease, I have to go to a cardiologist, not a gastroenterologist with gas problem. We know how many patients are dying daily with thinking, educated patients going and then dying with complaint of gastric trouble and then delays, and then many patients keep dying. Now, with this uncertainty happening, 3 major trials or recommendations change the whole set of management of coronary artery disease, especially in asymptomatic patients, or classical stable angina chronic coronary syndrome, or a patient coming to the emergency room with acute chest pain, whether low risk, intermediate risk or high risk, then based on the heart scores or whatever. So now things seem to be settling for us. And almost 7 years ago, this is the first article which created a lot of enthusiasm, debate, and in asymptomatic patients, whether you should go for coronary artery calcium. Looking at this, is it an additional unnecessary test? Does it give you more and above the current risk stratification methodology or ischemia test which we are following, whether it is going to help us or not? There was huge debate, right? And now, you know, it is considered as a part of a clinical assessment, just as you do, you know, auscultation, then clinical examination. You should evaluate and come to an assessment whether the patient 35, 45-year-old with one risk factor, hypertension, diabetes coming to you, and you should have coronary artery calcium to assess whether the patient is low risk, intermediate or high risk, not just, okay, take that colored charts and then draw a line, okay, 45-year-old female, okay, with the risk factors, PCE or your Framingham or SCORE or Q risk, Raynaud, whatever you call, then you say, okay, this is intermediate risk or low risk. Females, younger patients, we miss elephants. And that is how all over the world now, based on the following the guidelines, a lot of changes have come up. But before that, so the other thing, the NICE guidelines in 2015 and 2016 updates have brought in CTCA as first test and removed the pre-test probability, and then ischemia stress testing for any patient with stable angina or patients who are having chest discomfort suggestive of myocardial ischemia, have some ECG changes, T inversions or whatever, you should go directly for CTCA. That will save money and reduce the events and then give better quality. 1990s, that majority of the myocardial infarctions are because of 30% or 40% blocks or 50%, not 70-80% blocks. Because more number of 30-40% blocks are there. That is the reason why. And then probably more vulnerable blocks are there. We knew it, but anytime when even in 2000s, 2005, when I was doing an angiogram, I was telling my patients it's only 30%, don't worry. And then some people must have had, problems. So our judgment, our interpretation, our scientific knowledge was not sufficient to guide the patients properly. And we know that majority of the patients with acute MI present with less than, 50% stenosis. And this is proven, not only 1990s, this is proven in the latest registry data or trials, the Scott Hart trial, the Promise trial, the Iconic trial, and then the pooled analysis also say that it is, you have to give importance. And the CAC trials, CAC registries, what do they say? Mesa Calcium Consortium, patients with 30% stenosis have more than 3 times risk compared to no stenosis. So 30% is as important. People who have 3 vessel disease with a 30% have 6 times higher risk compared to normal coronary. So what we were saying, oh, nothing to worry, it is only 30%, it is there for every person, you are 60 years, it will be there. Some people don't have anything. They are absolutely normal coronaries. They do much better than these people with mild disease. So any patients, you see the 100 patients admitted in your ICU, almost 80% of them are so-called low risk category by all these risk stratification criteria, and they are never prescribed statins. And as we will see later, so statin use, misuse, and the current aspirin guidelines, which are relatively simple. Statin is much more difficult. And then significant number are under-prescribed, almost 40% or so. If you use the current guideline, which may not be applicable again in Indian subcontinent, whatever you take guidelines we don't have, they are not applicable because we are 2.68 times more vulnerable South Asian ethnicity. So we can't apply the same guidelines to decide about the statins. Then we keep talking about guidelines. So statins should be given 130, 160. I don't think these will apply in India. So when a patient comes in a sick status, it is okay. You apply your knowledge and then you try to do your best. But if a patient comes for screening, you have to be doubly cautious when applying the knowledge available on the scientific data and your own experience with that, expertise with that availability. And based on that, you should be doubly sure before advising, because you'll be doing more harm by suggesting wrong screening methodology, and that is the reason why in US some time back, you choose wisely. Whatever you choose, the available gamut of investigations to do best for the patient, you choose wisely. So this is the movement, and then there are physician payment modes also based on their ability, whether it is inappropriate test, appropriate test, and then payment modes also. Red circle is given for the physicians. So my sister was telling, they have been doing it for quite some time. You have to be very cautious, you have to follow the guidelines, at least, whether they are right or not, or partially right, that's a different thing. At least you should not jump the guidelines. So majority of the patients, they have either 0 risk factors or 1 risk factor, all the ACS patients. And then when the risk factors, as all Framingham and all these, they have done great job. But then they have not been able to identify, pick up the right kind of patient who is likely to develop problem. And then they have developed, then they have 200 minor risk factors have come up, permutations, combinations. We were doing a lot of other things, formula, complex formula and all. None of them could predict absolutely, even if you have angiogram, you can't predict what is going to happen. Okay, so these are the ischemia stress tests, different types of ischemia stress tests. And what happened? This data to say that patients who were sent for invasive angiogram after the ischemia stress test, more than 50% of them had less than 50% stenosis. And similarly, who were sent for routine angiogram also same. So ischemia stress testing results to an inactionable information. So what does it imply? And that is the reason why the NICE guidelines, they have removed ischemia stress test. If you have chronic stable angina, treat with medication, and if you feel, yes, it needs, go for directly CT coronary angiogram, no other investigation. So now the personalized disease-based risk prediction approach versus a traditional and then population-based risk prediction approach. And all these years we have been, working on this, guessworks. And until this particular investigation was introduced, coronary artery calcium. When coronary artery calcium, the paper was presented, it was refused initially. It was thought that it doesn't have much weightage. And subsequently when Donald Trump effect, so he underwent CAC 3 times. Only when he became president on the 2016 or so, that time when he underwent CAC, there was a huge search, Google search for CAC. So it attracted attention. So he needs celebrities sometimes. So this is how the calcium score, the normal condition, severe calcification. And this is how the coronary CT angiogram, which is measured now, 64 slice, 128 or 256, dual source, whatnot. So based on the type, what to do, what is the next, and then based on the patient's symptoms. So the type of the plaque, the Lehman risk segmental score, all these things you will take into consideration before advising the patient, and probably data will come up how we should evaluate. And in a country like India or in poorer countries, you can't have access for every patient for CT coronary angio. So now CAC, it is more predictive than any risk factor or stress test, but can we stop with CAC? What is the most other simpler test? So people have suggested a CAC with a exercise ECG can give better prediction model compared to the traditional conventional model which we are following. And there are a number of landmark studies, and then there is something like power of 0, very, very important. In mass screening, if power of 0 is there, annual incidence of mortality is 0.28%, right? And it is much better than people who have not gone for calcium score because you don't know what is there. So they fare worse than people who have gone for this. But this may not be applicable in non-patient. In Indian patients, if they come with chest pain, classical chest pain, don't believe in power of 0. We have several patients of power of 0 who had 100% blocks, 90% blocks, who have done PTCA. So we don't believe. So the power of 0. But for mass screening, because you can't do CTCA, but in Indian patients with the risk, probably 35-40 years, if they have risk factors, probably CTCA will give us for the next 10-15 years at least, or some guidance, better guidance for us to treat the patients. So after adding CAC, it has become better for pre-test probability assessment based on which we can suggest the patients. This is how we do. The calcium score 0, probably we don't give statins, but in certain specific conditions you may have to give, like diabetes, smokers, premature, history of premature coronary artery disease, likewise. And then if it is 1 to 100, then you have to individualize, and then probably more than 100, probably you have to give 100. If they have associated comorbid factors, you have to give moderate or high intensity statins. Similarly, aspirin, if it is more than 300 or 400, people say, in the morning you have shown some of the cases where whether the patient is fit for aspirin, diabetic patient or, some hyperlipoproteinemia. So then you have to do CAC and then take a decision, because it was shown that the number needed to treat to cause bleed or to have a thrombosis or ACVD events is different. And when it is more than 300 or 400, probably aspirin should be given in doubtful cases. Otherwise, statin is much better drug than aspirin, as we know, and definitely it has to be started at much earlier age, not at the age of 65 or 70, where we see a patient with myocardial infarction. Now the present belief is you have to start statin early when the patient starts having lesions which are more plastic, like 25, 30, 35 years. Start good dose, see that it is compressed, it is fibrosed, and by the age of 65, 70, even if you give statins, we do not know whether real good will be done. Maybe some good will be done. So now the two major myths about the accuracy of coronary CT angiogram and the radiation dose. So in 2011 when we started, many people were not believing that it gives the same accuracy as invasive coronary angiogram. And now we know that the limitations of invasive angiogram in bifurcation lesions, ostial lesions, it is not a 360 degrees positive remodeling. It doesn't give us any information. It doesn't give any information about the plaque vulnerability. And whereas now CTCA gives much more information, and then with good tests, with controlled heart rate, with good machines, with good technician and a radiologist and a cardiologist, you can definitely, now accuracy is 97%. CTCA and invasive coronary angiogram, now it is accepted. That is the reason why these 2021 guidelines, accuracy, radiation is less, and it gives, better predictive value, and the ACVD events are less if you base your therapeutic modality or investigations based on your CTCA. And this is what we did in the initial phases, both CTCA and invasive angiogram, to convince our own cardiologists, first of all, that yes, we are giving a good result, don't believe it, don't ask for, otherwise they were giving 50, 60, okay, let us do invasive angio. No, it is not needed. Unless the patient has got clear-cut evidence or you want to do FFR, then only you have to go for invasive angio. And now I'll show you. In fact, nobody was talking. In fact, invasive angiogram gives more radiation than the current existing CT coronary angiograms with your iterative reconstruction, step and shoot technique, low voltage, tube voltage, and the currents. So you can definitely cut down, and now it is 80% less, and it is less than invasive coronary angiogram. It is almost, coronary CAC is less than 0.37 millisieverts. It is coming to even 0.01. They are trying with the artificial intelligence. So it is much less and than a mammogram, which is almost 0.5 millisieverts. So radiation dose, and it is much less than a lumbar spine X-ray. So radiation dose, and all of us get background radiation of 2 to 3 millisieverts, depending on the geographic region which you are living. So radiation dose is very, very minimal, with CAC almost very negligible, 0.37. We are doing with, I'll show you. We are doing, okay? And it is less than breast or colon cancer. And then this is an alternative refine. And so one-stop shop. Now it is very clearly, categorically established, or many people believe that CTCA is one-stop shop rather than layered testing, wasting time, getting confused with false positives, false negatives, and then wasting time and money. And then most important, comparing with invasive angiogram, this, okay, I can do angiogram in 5 minutes, why you go for CTCA? Angiogram definitely has its own problems, and this is what it is. The dissection rate is definitely more, adverse events are more. Why you should puncture an artery when you can do it with a simple CAC or just a venous puncture? So then again, with all these things, with the angiogram, you are seeing only 5% of the coronary vasculature. Remaining all the vasculature, you are not able to see either with CTCA or invasive angiogram, and most of the black box is now in the microvasculature. We do not know how it behaves, variability of the functionality, structurality, what really factors affect that. And the indices, very invasive and non-invasive indices are there, and then we don't know, we have to wait. This is our, patients, how it progresses. We have seen 2011 to 2021, 14, then 13 to 16, more or less 20 to 25%. But if it progresses more than 25, 30%, then it is probably malignant. And some patients we have seen, it is not progressing at all, as I have shown you. So probably they fare better. They have a specialized immunity protection gene. We do not know what it is, either a gene protection for, either blood vulnerability or patient vulnerability or plaque vulnerability, or at some point of stage time, it develops very fast, we do not know. So, likewise, this is the CTCS which we have done with the 0.9 millisieverts, 1 millisievert. That was in 2011 or 2012 we have done. So, with very minimal, the technician has to adjust the dosage based on the body size, shape, then he plays a significant role in reducing the radiation. We can do with 2, 2.53, but if post CABG we do 4 or 5 millisieverts. Right? This is how 4 or 5 patients we have shown that we can do it with. And these are all the people who died unnecessarily, and they have done, probably these patients have 30%. Whether we could have prevented, we do not know, but at least some of the patients, or 80% of the patients who die between 35 to 50 years, they have definitely coronary artery disease, they have plaques, and if you find plaque, you give statin, you stabilize it, then you tell there is a plaque, there is a possibility, 50% plaque, then the patients go directly to the ER room. If some disease is diagnosed, if you show, many people stop statins, even in US, almost 68% people stop statins. They don't like to continue. But if you show calcium, if you show plaque, the adherence to the treatment is very good. So, this is what it is. And then, this is my own brother, he came from Hyderabad just to see me, say hello to me. Then I bought a CT, I was fascinated to put everyone under CT. So I put him, and then this is what it is. Then when I asked, he said, okay, when I climbed 2 flights of stairs, I was just getting a breathlessness, no pain. On that question, after seeing this. And I am very happy, though $2 million machine I purchased in 2011, but it saved my brother. This is a widowmaker lesion. You have seen this? The proximal LED lesion, 95%, a huge LED. And within a week's time, his own cousin died in sleep. He must be having a widowmaker lesion. He was also around 50 years. So this is what we did, and then this is how. And then, by doing 19,000 CT angios, you know what we did? We saved our radiation dose to our cardiologists and our cath lab staff, right? Otherwise, what were you doing? Okay, we are patting the patients when it is normal or mild CAD, and then we are getting the radiation and back pain, right? So this is what is happening. So this can be done for the young cardiologists. Don't just jump. You have to do. Yes, there will be cases now the issue is how we are going to do. Yeah. So these are the 10 scientific facts. The coronary atherosclerosis starts in 20s and 30s, unpredictable and uncertain progression, and therapeutic lifestyle changes for all in statins in selected patients in young age. Pathobiology of atherosclerosis, ACS is different from CCS. Physical fitness cannot be equated to cardiac protection, genes, risk factor, environment, we don't know. Traditional risk stratification models are quite inadequate and personalized, and the precision medicine is the order of the day. Ischemia stress testing often gives inactionable information, and more than 50% prescribed inappropriately, even in the United States. Forget about the Indian risk factors and the way, the variation we follow in India, with urban rural divide and everything. Therapeutic decisions regarding interventions based on moderate or severe ischemia are questioned with recent scientific data may not be gold standard in every case. Therapeutic decisions based on eyeballing interpretation, most experienced cardiologists, when they look at the angiograms, 30 to 40% of the times you are wrong, and even the heart teams, they have to change 12-13 times, 12-13% of the patients in syntax 3 trial to change the decision with regard to the mode of treatment or even the vessel which needs to be addressed. CABG seems to be superior to PCI in left main and triple vessel disease, more so in diabetics. In specific cases, yes, PCI may have equal results with surgery, CABG. Coronary artery calcium, CTCA, vulnerable plaque, power of zero, CTFFR and one-stop shot are buzzwords now for most cost-effective management of CAD. How it is applicable in India and in this area, we have to work with the physicians and then with the public health authorities. So proper addressal of gaps in knowledge, denial, accessibility, accountability, inequitable resource allocation, appropriateness of mass screening methods, myths, biases, AI applications in RCTs, etc. will definitely bring down the incidence of cardiac death. So what should physicians do? They should have coronary artery calcium in a patient more than probably 30, 35, 40, in India, shared patient decision. Get a CAT done. It is part of your examination. You can't just judge whether the patient has got peep into the coronaries. Don't guess. So this is what it is. And then cascade screening and reverse cascade screening. Hypertension, diabetes, hyperlipidemia, premature CAD. Catch hold of the first degree, second degree, third degree relations. Do a proper screening methodology. You will pick up some patients who are likely, rather than a mass telling everyone to get, to to follow guidelines, yoga exercise. For people who are immune to atherosclerosis, Amazon, there is a place where, in 70, more than, even 75-year-old, only 5% have CAC. Majority don't have any CAC. They are hunter-gatherers and all. So there is a lot to be learnt from their lifestyles and everything, and identify hidden heart disease. So general physicians can ask for a CAC and CTCA based on the, their suspicion. And if it is mild or moderate disease, they need not refer to the cardiologist. They can start statin. They know how when to start aspirin. Strict control of blood pressure, 120 or 120 is systolic blood pressure, it is fine. And then strict control of the lipids, 55, 70, 100, whatever it is, based on the guidelines. Guidelines may not be applicable, but still you decide what it is. And then treat mild, moderate disease and utilize the telemedicine, tele-ICU now, which is now found very useful in the COVID era. Everybody knows what is telemedicine. In our setup, with the central command station, we can monitor any patient of 700 patient beds across the cluster. With a very, very cost-effective strategy. 24 hours, we have a third eye. We employ a person to look at the monitors only. ICU nurse cannot look at the monitors. So we find out VT or any hypoxia or anything, and then immediately they give an alert. There is a speaker, they tell, and then immediately the sister and the doctor respond. And this is how we are trying to prevent certain cardiac death in ICU patients or in-house. And this we can give to the even physicians who are practicing outside. If they want their patient to be monitored, we can monitor from our central command station. Definitely we can do it, and we can provide telemedicine for you. You send an ECG and then give the history. We can suggest to you what is to be done. So all these things, yes. So more cardiology patients will be treated by general physicians, and more critical, and really our time will be utilized, the cardiologists. So there should be some sort of a clear awareness and understanding, and see in this area what we should do. So this is our idea of conducting this CME program, basic idea, how we can try to address the issue which we have been watching for 30, 34 years. Still the other day, 2 days back, a person went to a doctor, RMB doctor of course, so night time, so gastric trouble, gave pantocid, double pantocid infusion. Morning he had pain again, he said it is a massive gastritis. Right? Patient came by 6 o'clock with edema and pulmonary edema, shock 6.9. We did angiogram, angioplasty, patient died. Just about 1 week back, 2 weeks back, Dr. Somaraju inquired about it. So this is what is happening. The flight of status and cases what we have been treating, dealing with. But anyhow, ultimately trying to do the best in the available circumstances. We have excellent team here, dynamic people who are doing day and night, angioplasties. Whenever a patient comes, the target is to do it less than 60 minutes, 40 minutes, to bring down the bar to do the angioplasty. We don't delay, and we are, even cost and all, we are trying to see how we can adjust. So this is how there is a huge scope with the available resources, with the available, without much cost. Almost, I have a feeling that we can cut down sudden cardiac death by 50% if proper awareness and proper utilization of the available resources are utilized. So this is what I wanted to convey, and the reason for this CME also, apart from the other common conditions which you see, perioperative risk and all, very, very common you see. So all these things will be dealt with by our colleagues who have prepared very well. So thank you once again for patient hearing. I don't know whether I have bored you, but this is a passion. So I tell you one thing, like, IABP and CTCA, certain cardiologists believe with passion and they are right. And some cardiologists, no, it is useless test, right? Both may be right, both may be wrong, we don't know. And there are certain cardiologists and physicians who are caught between the tide and the hard rock, and they do not know what it is. Probably this will help some of them to give a thought, not to make a decision. And we have given a printout, like 200 pages, articles which contain the information which is being covered from morning to evening, some of these things which you may have missed. So this probably gives you a little more insight from the reputed journals. So thank you again.
Thank you, sir, for such a wonderful speech. Now I call upon Dr. V. Anup for the topic STEMI, Platinum 10 minutes, Golden 60 minutes, and Pharmacoinvasive therapy is ideal in India.
Just a minute. I'm sure there will be many questions. After Anup's case, then we can have some questions, right?
Hello. Good afternoon. This is going to be a short discussion on how important are reperfusion strategies and what is the role of pharmacoinvasive approach in India. So I just want to begin with a small case scenario. So this one is 60 years old gentleman who had chest discomfort for the past 2 hours, and he was hypertensive and a smoker. BP was 110/70 and pulse rate was 98, and CVS and respiratory examinations were normal. ECG showed ST elevations in 2-3 and AVF, and echo showed an ejection fraction of 45%. So this was the ECG. So the patient has reached the emergency non-PCI capable center. So at this point of time, so what would be the better strategy, reperfusion strategy? So what to choose? So of the options, one is either we do thrombolysis and stabilization at the non-PCI capable center, or we do a thrombolysis and plan for PCI within 3 hours, and then we do thrombolysis and then plan for a PCI within 3 to 24 hours, and then shift to PCI capable center immediately. So what did we do? We thrombolized with IV bolus of tenecteplase, and then our door to needle time was 35 minutes. So we did thrombolysis and we immediately planned to shift for a PCI capable center and planned for an angiogram in 3 to 24 hours. So here the question is, why did we choose this approach? So the most important thing here is the transfer time for us. So from our non-PCI capable center to the PCI capable center, it was almost like 60 to 80 minutes of transfer time. So we thought that the best reperfusion strategy would be you do thrombolysis and then shift to PCI capable one. So immediately we shifted the patient to the PCI capable center by the EMS team. So during the transport, the patient had 2 episodes of EF and loss of consciousness, one during the transport and one on reaching the PCI capable center. So both were successfully reverted with a DC shock. So what did we do now? What to do? So this was the angiogram of the patient. The OM was 100% blocked. It was a huge OM. We opened it and then we placed a stent. So we have done a rescue PCI in this patient. So what I like to put, like different reperfusion scenarios I want to discuss and what strategies we would choose in these scenarios. Okay, so there is a 54 years male who is hypertensive and diabetic and chest discomfort since past 30 minutes, and the patient has reached the PCI capable hospital, and ECG showed ST elevations and V1 to V4 and the echo was EF was 45%. So definitely there is no confusion. Probably we would opt for definitely the option is primary PTCA. And the time metrics, probably the timelines which should be followed in this case was the ECG should be done within less than 10 minutes and should be interpreted, and then the door to balloon time should be less than 90 minutes, and lesser it is more better. So we have one more case scenario, 46 years male who is a smoker and chest discomfort for the past 30 minutes and who reached a non-PCI capable hospital which is 30 minutes away from the PCI capable one, and the ECG showed ST elevation in V2, V4 and the echo EF was 40%. So what would be the best approach we choose in this patient?
Can I ask the moderators regarding this? Patient came with chest discomfort 30 minutes from a non-PCI center, that is from periphery. So with the ST elevations from V1 to V4 and echo with EF 40%, what should be the next line of management?
If the patient is hemodynamically stable and if any nearby PCI capable center is there and there the door to needle time or door to balloon time, as Dr. Ramesh sir has told, it is less than 30 minutes, we can safely transport to the PCI capable hospital. If the PCI capability facilities are taking more time, then we can thrombolize there and we can, after stabilization, we can shift him to the PCI capable hospital.
Yes, sir. Here, both the options of thrombolysis and the primary PCI both are good. Like if shifting to the PCI capable hospital, the first initial 2 hours are like really very, both thrombolysis, especially in the first hour, even the thrombolysis has equal efficiency compared to the primary PCI. So if you think that shifting to the primary PCI capable center is 30 minutes and then where we need to spend extra 60 minutes from door to the balloon, so probably it will take extra 90 minutes. So even in this case, thrombolysis also can be a good option, likewise PCA, primary PCA. So here also the time frames are less than 10 minutes should be achieved for taking the ECG. And if we plan for a thrombolysis in this case, the door to needle time should be less than 30 minutes. And in the newer ESC guidelines, from the time to ECG, after interpreting the ECG to the thrombolysis, if it is less than 10 minutes, it is even more better. So we have this one more scenario of 58-year male who is hypertensive and diabetic and chest discomfort for the past 4 hours, who was in the non-PCA capable center, and there is an elevation in 2, 3 and AVF. So in this scenario, if the door to balloon time is greater than 120 minutes, we would prefer a pharmacoinvasive approach, like do a fibrinolysis and shift the patient for a PCA in 3 to 24 hours, or if door to balloon time can be, if we can get it done within less than 120 minutes, the primary PCA would be the better option. So now the question is the 12 hours. The patient had chest discomfort for 12 hours. He is in the non-PCA capable hospital. So what would be the best approach in this case? What would be the best reperfusion strategy we can do?
Sir, any inputs from the moderators?
Yeah, within 3 hours, PCA and thrombolysis have been shown to be equal efficacy. But if the patient window period is almost 12 hours, here clearly PCA has been shown to be superior than the thrombolysis. Because the thrombus burden after 12 hours of window period is going to be high. So it is better to take in for the primary PCA than thrombolysis.
Yes, sir. So, but in the Indian scenarios, most of the times we have a late presentation, like the patients keep coming almost after 12 hours or after 1 day. So, in our in this guidelines, even the thrombolysis is good, even for 12 hours, even up to 12 to 24 hours in some cases if the patient have some symptoms. So, this door to balloon time of less than 20 minutes or greater than 120 minutes even applies here. So we can either do a pharmacoinvasive approach if we can, if we don't get a D2B time of 120 minutes, or we can go for the primary PCA if we get in less than 120 minutes. So we have one more scenario of a 58 years male who is asymptomatic at 16 hours, who has been in the non-PCA capable center with elevations in 2-3 AVF. So probably in this case thrombolysis doesn't have any role. So the patient has to be taken to the PCA capable center because the patient is asymptomatic and there is no role for fibrinolysis here. So we have one more scenario of a 58 years male who has chest discomfort for 4 hours. He is in the non-PCA capable center, the patient is in cardiogenic shock. So possibly here there is no role for fibrinolysis here, though the patient is having only discomfort for the past 4 hours in the non-PCA capable hospital. There is no point of door to balloon times here. The patient has to be taken for the primary PTCA. So now again, what is the pharmacoinvasive approach and why is it even more important in the Indian scenario? So pharmacoinvasive approach is like one, we have to do the early fibrinolysis and immediately transfer to a PCA capable center, and we should plan for a routine angiogram within 3 to 24 hours. So in the event of fibrinolytic failure, a rescue PCA should be done within less than 3 hours. So getting the data from the Indian registry, though this data is already a decade old, we can see the number of primary PCAs done are less than 10%. The number of primary PCAs are very less. The reason could be because of the awareness or the lack of PCA capable laboratories, finances, or lack of proper EMS support and all. So if you can see from the studies, the outside India study, the STREAM trial or the STEP-MS study which has been done in India, so never this pharmacoinvasive approach can never ever replace a primary PCA. But in the Indian scenario where the primary PCA is not always, it cannot always be done. So even the pharmacoinvasive approach is one possibility to have results similar to primary PCA. So the combined primary endpoint of death and shock or congestive heart failure reinfarction was similar between the groups at 30 days and 1 year between the pharmacoinvasive approach and primary PCA. So if possible, always the primary PCA is the approach, is the gold standard. But if not possible, then pharmacoinvasive approach also can be considered if the door to balloon times cannot be matched. So what does the guidelines say? The CSA position statement says that all thrombolyzed patients should be considered for pharmacoinvasive therapy within 3 to 24 hours. And the ACC guidelines give a class 2 indication and the ESC guidelines give a class 1 indication for this. Thank you.
Any inputs from the moderators?
Yeah, I have a question to Dr. Ramesh sir.
Sir.
Yeah, I have a question. Actually, we have the identification of individuals, the risk of, we have various scoring systems. Now we have calcium score that definitely increases the incremental value for identifying these high-risk patients. What about giving ecosprin and statin for based on the zero calcium score and LAD 20% stenosis. Is it subjective or objective, or whether these patients should get the benefit of ecosprin and statin or not? Calcium score is 0, LAD 20% stenosis, asymptomatic, and treadmill was negative.
If this is something like 75-year-old person.
Yeah, if it is something like a 75-year-old person and the lesion is in the distal LAD, right? Probably I will not start either statin or aspirin. On the other hand, if it is a young patient, 30-year-old, 30% lesion, okay, otherwise no symptoms to suggest that it is a vulnerable plaque, or not symptoms in a sense that it is not a vulnerable plaque by CTCA, then probably young patient still he may be benefited by a statin and targeting a dose of maybe around 70 milligrams of LDL. There is no clear answer because you can't apply the same principles for India, but if it were to be my patient, I'll start to target around 70 to 100 milligrams of LDL if it were to be young patient. If it is old patient, I will not do anything. He doesn't need aspirin. Thank you, sir.
Thank you, sir. Thank you for the talk, Dr. Now I call upon Dr. Harda Madam for her lecture on ACS with comorbidities.
A very good evening. Post lunch, all of us are dozing. I will not take much of your time. These are all the case scenarios which I just want to mention. This is the first case, 58-year-old male, diabetic, hypertensive, complaining of exertional breathlessness, class 2 since 1 year. Echo and ECG normal, and he is not evaluated for CAD. He is having epigastric pain on the day of presentation, and since 2 hours having breathlessness at rest and orthopnea. He is already on aspirin statin, and his anemia was diagnosed as autoimmune hemolytic anemia and was on intermittent deflazacort. So at presentation we could see that there is gross pallor, tachycardia, hypotension and bilateral Krebs and with hypoxia. This is the ECG of the patient. So we could see clearly that it is an anterior MI. So echo, moderate LV dysfunction with small LV clot. Hemoglobin is 7.3. So the diagnosis is obvious, coronary artery disease, acute anterior MI, cardiogenic shock, CLIPS class 4 with chronic anemia. So what is the approach? So how we should deal with this case if we have gross anemia with anterior MI presenting with chest pain and class 4 breathlessness?
This patient has anemia. Anemia is a thing to be discussed in stable angina, but here the patient has acute coronary syndrome and troponins are elevated. So I think anemia should not be worried about too much. I think we should go ahead in treating this acute coronary syndrome and maybe plan an angiogram also.
Yes, sir.
Can it
As
be
he
a
is in
type 2
cardiogenic
MI?
shock, V2.
Can we consider type 2 MI here, sir, in this scenario? Anemia and anterior MI.
You mean secondary to anemia myocardial infarction? He says a secondary to anemia, the MI can occur. But it is only MI. Anemia is a comorbid condition, and symptoms of chronic anginal equivalents can occur. But ECG of ST elevations and all won't occur only in anemia. Mostly anemia is a comorbid condition here.
When you see a localizing sign with reciprocal changes, it indicates a geographic area. So if you see this kind of a problem with mild LV dysfunction and mild drop T elevation, it can be a type 2 MI. When you see a regional localization, wall motion abnormality, it points to a local problem. Over and above, of course, anemia can be contributory. Secondary, this is not anemia of bleeding. This is anemia of excess destruction. It doesn't have the same prognostic value. You can safely take this patient to the cath lab.
In the same lines, we went to the cath lab, took the patient for primary PCI. So this was the angio done, LAD 100% occluded, stented the LAD. Patient had persistent breathlessness with severe LV dysfunction, and there was a further drop of 1 gram per deciliter on day 2. So after discussions, we transfused PRBC for this patient as he is not improving. So in the workup, we did a chronic anemia workup. Reti count was 2% and his stool for occult blood was positive. So for our surprise, colonoscopy showed a stricture with mass lesion. So on colonoscopy, we could see a bleeding mass lesion. This was not diagnosed and it landed up in a big mess. So patient had blood loss. At the same time, we should not give him antiplatelets or anticoagulants despite the LV clot. For this patient, anemia diagnosis, early diagnosis would have been better, and as the patient is having breathlessness, it was considered that it is due to anemia and not evaluated for CAD. Whenever any patient has anemia and ACS, it is a deadly combination, because if we give blood transfusion in a post-stent patient, it can cause stent thrombosis. So in this patient was added upon the things. He was given steroids continuously, thinking that it is autoimmune hemolytic anemia.
Sir, any inputs?
I'm sorry, I thought this patient had a documented warm antibody anemia. It was a mistaken diagnosis. Retic count was only 2%.
It was a false positive Coombs test, sir.
Okay.
So because of the bleeding also, he had false positive Coombs test.
Anita, if you have hemoglobin of 7, definitely this patient comes under high bleeding risk patient, irrespective of whether he is having bleeding symptoms or not. So what are the preventive measures do you advise prior to the implantation of the stent? Because this is definitely high bleeding risk patient, we need to take certain measures, definitely he is going to bleed somewhere.
The only thing we can do is we can prevent giving ticagrelor aggressively, the novel drugs, and at the same time keep ready the blood RBC readily so that we can infuse it as early as possible.
Do you recommend a BMS, bare metal stent, where we can even give only...
Actually nowadays we don't have BMS in the stock also.
What about third generation DES?
Initially I thought I would do only a balloon angioplasty, not a stent. But after doing the angioplasty, I couldn't get the TIMI flow. So I stented this patient. And nowadays in our lab, we don't have BMS also. Previously we used to practice, but now we don't have.
Thank you.
I have a few of my patients where internal occult malignancy got manifested after stenting. I don't use much of ticagrelor, but one patient I used ticagrelor. After 1 week, he had massive hematuria, full blood coming out. So I thought we evaluated, there was only kidney stone was there. The urologist was very definite, stone will not cause so much hematuria, something else should be there and all. I stopped ticagrelor, switched him out to clopidogrel, then waited third month follow-up, absolutely fine. Fourth, fifth month, he came back to me for cardiac fitness for surgery. Then later they detected carcinoma in the kidney was there. Then he underwent surgery. Then again another bladder tumor, polypoid tumor was there. After PCI, he had hematuria and the bladder tumor was there. Another was colonic cancer only, but she was mitral valve replacement. After replacement, anemia became worse. And then she was evaluated, family history, everything was there. So then she also underwent, that was a nightmare for me to stop the anticoagulants, adjust it, tide over and everything, but she did very well.
Thank you, sir. This is the second case. I would go fast. A 12-year-old female patient presented with fever, acute onset chest pain. This is the ECG. So, any comments? So, we could see that inferior wall QS complexes, T-wave inversions, classical ST elevation, ST depressions in V1, V2, V3. So, echo showed moderate LV dysfunction. Her HB is 6 and evaluated for anemia, iron, everything is normal. The only abnormal points are CRP is high, ESR is high, peripheral smear normocytic normochromic anemia, Coombs test negative. We went for CT coronary angio in this case, and as it is a 1 week old pain, so it showed no significant stenosis. But despite no stenosis, patient developed a transmural scar in the inferior wall. So our initial diagnosis was type 2 MI with anemia. So she was given blood transfusion, she recovered very well, went home, and afterwards again came back with recurrent episodes of fever, creatinine 2.2. Now this was associated, Coombs test was positive and APLA positive, ANA positive, and kidney biopsy showed lupus nephritis. So there are so many combinations of problems presenting in young patients. Especially if there is anemia, we have to thoroughly evaluate anemia, and giving blood transfusions during anemia is a big trouble for the cardiologist. So the viscosity of the blood increases after transfusion, and it increases the systemic inflammation and erythrocyte plugging and causes stent thrombosis. So the next entity I would like to discuss is the aggressive or accelerated atherosclerosis that is commonly seen in some of the subsets like autoimmune diseases, retroviral disease, CKD patients, post-transplant patients, and a small subset of young Southeast Asians. So this is the depicted picture we can see. In around 13% of the Indian population, we could see the aggressive atherosclerosis that is there. The plaque progresses 22 times faster than the normal person growth. So they are called high growth individuals. So they don't have the regular traditional risk factors. Similarly, in autoimmune diseases, before the disease starts, before the arthritis starts, before fever starts, atherosclerosis subclinically progresses. So how to identify such subsets? Total cholesterol LDL will be normal, HDL will be sometimes high also, but this HDL is pro-inflammatory HDL which is detrimental. Coming to the drugs that are given in autoimmune diseases, they cause hypertension, hyperlipidemia, and the deadly drug is the corticosteroids which cause hypertension, hyperglycemia and hyperlipidemia. So these are all the markers. So HIV is one subset. We are now frequently seeing premature atherosclerosis, especially when the patients who are on antiretroviral drugs, and because of the drug interaction between these drugs and statins, they are underused. So the inflammatory bowel disease also, because of the hypertension, high homocysteine and CRP levels, there is an increased incidence of coronary artery disease. Coming to CKD, this is a 41-year-old patient who presented with this ECG. So he has got an inferior wall MI, QS complexes, lead 2, lead 3 and AVF, with small ST depressions in lead 1 and AVL. T-wave has already inverted, but the patient was complaining of chest pain. So we did an angio, RCA is 100% cutoff. So same patient, the atherosclerosis is so aggressive that he has got a complete occlusion of the aorta and the descending aorta, and the lower limbs are perfused with collaterals. So the CKD is one more entity wherein the pathology is very aggressive despite a normal LDL and a high HDL which is seen, and that because of the dysfunction of HDL. And there is a significant calcification that is prominently seen in the arteries in CKD patients. So early diagnosis is vital, though most of us neglect this CKD entity because of the risk of further progression of the disease, but the fatality is very high in this subgroup. Thank you.
Sir, one question, sir.
The second
this-
patient,
yes.
one question is, it could have been an associated myocarditis. So when you put about 15% of patients with lupus or rheumatoid arthritis, they can have a focal uptake of gadolinium and have infarct-like presentation. The thing that will differentiate is if you have an FDG uptake also around. So then your threshold for starting immunosuppression becomes very low, and you will probably start them very early on day 1 or day 2 itself.
Yes, sir.
The same. Any more inputs?
Nice cases, Harita. Congratulations.
Thank you.
Thank you, madam. Now I call upon Dr. Jairam Pai sir and Dr. Shivprasad sir for the dash talk, delayed diagnosis of complicated MI and emergency CABG and surgery beyond CABG.
Respected chairpersons, dear ladies and gentlemen, first I'd like to thank Dr. Ramesh Babu for giving me this opportunity to speak. I find most of you are drowsy, difficult to concentrate more than 1 hour after lunch. Now you can understand how difficult for a surgeon to do a acute emergency CABG when we call afternoon after lunch or night after 12 o'clock to do a 4-hour surgery operating on a coronary artery which is 1.25 millimeter or 1.5 millimeter size. Our accuracy of CABG has to be such that our results has to be perfect, and there should not be any easy changes in the post-operative period. So now you understand our difficulties. So indication for emergency CABGs are ongoing ischemia in the presence of left main or critical DVD, ongoing ischemia despite of optical medical management, or failed percutaneous coronary intervention in the patients with ongoing ischemia, or patient with PCA, eventful or complicated PCA, cardiogenic shock with complex coronary anatomy where it is not suitable for angioplasty. Life-threatening left ventricular arrhythmias in the presence of left main or critical triple vessel disease. Emergency CABGs in acute coronary syndrome represents 3 to 5% of the total CABGs. Beating heart surgeries preferred in hemodynamically stable and non-arrhythmogenic heart when ejection fraction is more than 30% with pre-operative low dose of inotropic support, older age, renal dysfunction and neurological dysfunction. Beating heart surgery advantage in acute coronary syndrome is less drainage, less inotropic support, short ventilation time, short ICU stay with lower incidence of acute renal failure. But one should not hesitate to go on pump in acute MIs if patient has got left main disease with significant circumflex disease or critical triple vessel disease with hemodynamically unstable or arrhythmogenic heart. What literature says? Hospital mortality rate when CABG was performed between 6 to 23 hours after onset of symptoms, that is MI. In ST elevated MI, the mortality is 13.6 to 23.8%. In non-ST elevated MI, it is 6.2%. If you see acute ST elevated MI, mortality rate for the patient undergoing CABG within 6 hours of onset of symptom is 10.8%, and between 7 to 24 hours after the onset of symptom, it is 13.6 to 23.8%. Highest mortality seen in left main disease with cardiogenic shock, it is 40 to 55%. Total number of emergency CABGs done in acute MI at our Dr. Ramesh Hospital, both including Guntur and Vijayawada, is 438 cases among 9,110 elective cases. This between December 2014 to December 2021. This is the highest reported number in the given center in the entire India and even in the world also. The age of the patients are between 32 to 89 years. Age is not the criteria. Any age with above indications we can take for a surgery. I just remember this 89 years old patient, he came with anterval MI with pulmonary edema with cardiogenic shock. He has been intubated and IABP was placed. We have took him for a CABG in 24 hours and we put 4 grafts. This man recovered. He is still doing well. He is 4 years from day of surgery now. He is now 93 years, still doing well. Male to female ratio is 2.8:1. Diabetes mellitus is 141 patient had diabetes mellitus, 245 patients had hypertension, and 39 patient had old MI. 363 patients with ST-elevated elevated MIs underwent emergency CABG. 75 patients with non-ST-elevated MI underwent emergency CABGs. Cardiogenic shock is seen in 121 patients. On doing angiogram, 9 patients had single vessel disease, 54 patients had double vessel disease, 293 patients had triple vessel disease. Left main with triple vessel disease seen in 82 patients. PTCA with stenting was done in 10 patients 3 to 5 years back. Emergency PTCA POBA is done in 43 acute coronary syndrome patients who required CABG. That's POBA done to LAD in 21 patients, POBA to RCA for 17 patients, and POBA to circumflex in 5 patients. Average number of grafts were 2.9. 100% of the patients received graft to LAD territory. 76% of the patients received graft in circumflex territory along with LAD territory. And 63% of the patients received grafts in RCA territory along with LAD territory. CABG was performed within 5 hours to 6 days after the onset of symptoms or MI. Within 24 hours, we did 153 patients. Between 24 hours and 6 days, 285 patients underwent emergency CABG. LEMO was used in 89% of patients. Total number of beating heart surgeries were 394. Total number of on-pump CABGs were 44. Conversion of beating heart surgery to on-pump surgery in 9 patients, that is 2% of our patients required conversion from beating heart to on-pump surgery. Pre-operatively, 192 patients were put IABP in the cath lab itself. Post-operatively, 26 patients needed IABP. IABP support was used for 48 to 84 hours. Inotropic supports were used between 48 to 120 hours. Blood was 500 to 600 ml in off-pump, 700 to 800 ml in on-pump. Average unit of blood required was 3.2 units. Our elective surgeries actually doesn't read, our average requirement of blood is 0 to 1. In emergency MIs, we use average blood is 3.2. This is because cardiologists usually give a loading doses of all antiplatelet drugs and they come to us immediately after loading dose. Re-exploration seen in 11 patients, that is 2% of the patients. Total ventilation time is 19 hours. Re-intubation seen done in 2.73% of the patients. New MI seen in 2.5% of the patient. Post-operative AF is seen in 17% of the patients, all reverted to normal sinus rhythm at discharge. Post-operative course shows 2.2% patient had strokes. Acute renal failure seen in 3% of the patients. JA complications seen in 2.2% of the patients. Sternal wound infection seen in 9 patients. Literature says timing of the coronary artery bypass grafting after acute MI remains controversial. Emergency CABG after acute MI clearly associated with high perioperative mortality, which ranges from 4 to 32%. And it also shows overall hospital mortality was 16%. Hospital mortality in CABG performed within 1 week of MI was 46%. And hospital mortality, this is the one more literature says, hospital mortality in the patients were 38.9% and 5-year survival is 55.6%. If we take our post-op course, average ICU stay is 4 days and 12 hours. Average hospital stay is 9.5 days. Our hospital mortality is 5.2%. Late mortality is 1.21%. If we look into the rejection fraction, almost all patients had 5 to 10% improvement of ejection fraction in their postoperative follow-up period. If you look into the world data, National Database Thoracic Surgeon USA, they have done 819 total emergency CEBGs in MI in their 7,74,881 total CEBGs. We have done 438 emergency CEBGs in 22,000 total CEBGs in Ramesh Hospital. If you see, German, they have done more than 130 cases, emergency CEBGs. Japan has done also 100 CEBGs, and we have done more than 439 cases. We have compared our results with the centers which has done more than 100 CABGs in a given center. In Japan center, one of the centers, they have done 186 cases. Their hospital mortality is 38.9%, 1 year survival is 58.6%, and 3 year survival is 55.6%. The Columbia University, New York has done 174 cases. Their hospital mortality is 43.6%, 1 year survival is 54%, and 3 year survival is 52.6%. Our hospital, we have done 438 cases. Hospital mortality is 5.1%, and 1 year survival is 92.6%, and 3 year survival is 89.3%. By conclusion, mortality predictor in acute coronary syndrome is left main coronary artery disease and cardiogenic shock. Extent of ischemia and myocardial damage can be reduced by early IABP insertion. Mortality can be reduced by minimizing the door to CABG time. Thank you. Thank you.
Thank you, sir. Lokesh, sir.
Thank you, Dr. Pai, for an excellent presentation of your experience of surgery in acute coronary syndrome at the Ramesh Hospitals. Undoubtedly, it is one of the largest series that have been published in the literature addressing so many, and we have such a low mortality, 2%. The STS database says the mortality is 3%. We have got very wonderful results by timely probably initiating the IABP support well in advance when undertaking the surgeons of this thing. And most of the patients are undergone CABG and beating heart in our series. I think all over the world the report says that a patient with acute coronary syndrome, off-pump CABG is the choice of operation rather than on-pump CABG, unless the patients have got hemodynamic instability that they will not sustain the off-pump CABG. So this is one of the latest trends in the indications for off-pump CABG. I think it's a very wonderful series that I think you have to publish early so that the information is there. So we have also, in India, now we are entering the data in STS database. So we have compared the Indian results to the STS benchmarks. To our surprise, we found the incidence of acute coronary surgery for acute coronary syndrome is higher than the United States itself, and our mortality is less than 1%. In the entire India series, we have registered 4,000 patients. which we are going to publish soon. So the Indian coronary surgery, as now it is reaching to the number of surgeries performed in United States. Probably by the end of this decade, we would cross the United States in performing CABG. Actually, we need much more CABGs to be performed, and our population may be 3 times what now presently we are doing. This year we are going to cross 2 lakh CABG procedures for the annum. Thank you. Very nice presentation.
Thank you, sir.
Thank you, sir. Thank you for your wonderful comments.
For some of you who do not know, Lokesh Rao and I were classmates, roommates, along with Dr. Prabhakar, Akira Hospital, and very close friends. And I'm very happy that Lokesh Rao, now he is the thoracic president of Indian Society of Thoracic Surgeons. Yeah. He is the president, and he has a lot of mind on research. I used to remember we were roommates, and after dinner in the night we were sitting, Prabhakar and myself. So he was always mentioning about Christian Bernard and heart transplant. It was finding, and then now he is doing some innovative work in India, which is being recognized, and hopefully he may be nominated for Nobel Prize, in future. So that is our strong wish, and let us see. Okay, right. Thank you. And Jairam Pai sir, our people work hard. You work hard and you write hard also. Our people don't write papers, right? So, guide them. Okay.
Next, Dr. Suprasad sir for his talk. Can you put it on? Yeah, so rightly said, post-lunch session, but whatever we receive in emergency cases, they're all post-dinner sessions. And these cases, most of the time we operate in night. The today's topic which I am going to discuss is cardiac surgery in ischemic heart disease beyond CVG in a delayed post-MI patients. Means all these patients who have come with complication following MI, though we refer them as acute MI, acute MR and all, but usually they have got a delayed presentation, then they land up in surgical cases. These are all clinical entities like acute MR, post-MI ventricular septal rupture, LV aneurysm, LV rupture, sometimes very delayed presentation after MI with a dilated LV with a large coronary segment. These are all clinical spectrum and manifestation as a delayed presentation following myocardial infarction. So instead of discussing all the statistics and academics, I thought of introducing how we manage these cases in our OT rather than telling all the academics. So I'll explain each. We have taken individual cases as example. As a surgeon, what we do in our operation theatre and how we manage these cases and what is the thinking process behind these surgeries. I'll talk of an acute ischemic MR. These are all etiologies and the percentage of statistical incidence and prevalences. See, when any acute MR presents, we need to stabilize them medically and plan for emergency or early CABG. Either surgery we choose either mitral repair or mitral valve replacement with CABG. One of our case who presented was referred from private hospital with having a chest pain of more than 3 days. He visited a private hospital with orthopenic condition and he was referred from there to our hospital in evening. He was in NABH class 4. When we presented, he was totally breathless. We put in a CPAP mask and immediately we did echo, did all emergency this thing. We intubated him, put him on mechanical ventilator and inserted arterial lines, all invasive lines, and inserted IIPP balloon. Once we stabilized him, we took almost 30 minutes to 45 minutes to stabilize him. We wheeled him to cath lab. Before cath lab, this is this echo picture which is showing left ventricle. This is LA. You can see the mitral wall, there is some chordal rupture here with a severe MR. Immediately we took him for angio. Angio showed left coronary, this L6 is a lesion. There is one more lesion in the LAD territory here. In the same LAD, the proximal segment of the LAD is stenotic. These are all stentable lesions. The right coronary also showing quite stenotic area. So if this patient would have come in early at the onset of chest pain, maybe would have stented him and wouldn't have landed up in a mechanical complication of acute MR. Instead, his presentation was delayed, so he landed with us as a surgical case. So immediately we wheeled him to, after angio, we wheeled him to OT. We did mitral valve replacement with the St. Jude mitral valve. This was the intra-op TE showing left ventricle. Here you can see where my cursor is there. Papillary muscle is ruptured here with a severe MR. After valve replacement, the left side, this mitral is functioning very well, and there is no paravalvular leak. LV function is also near normal. He was discharged on day 9 with NABH class 1 with optimized INR. This was a case of where we did mitral valve replacement. In another case, where ischemic MR with acute MR presented with a severe MR, and we took him for surgery. We did CABG with mitral valve repair. The angiogram shows LAD, LCX territory with diffuse diseases. Soon after repair, MR is vanished, LV function is near normal, and the patient got discharged early. Doing mitral valve repair in such cases is very tricky because the left atrium is very small. I am sure Dr. Sajja sir will also accept it. And doing mitral replacement in such cases are better. But we thought of doing mitral repair in this case because we wanted to reduce the time and do it quickly, repair with alpha stitch and enveloplasty ring, and came out very fast. He was discharged on 6th day. In last 2 years, we have operated 5 cases of acute MR with CABG. And all these cases have received quick medical optimization, IBP insertion, and very emergency surgeries. Another mechanical complication because of a delayed MI, who often present with a dreaded thing, or almost like most of them have sudden death, is an acute LV free wall rupture. One of us patient who was referred from Narasarapet, Dr. K. Srinivas Reddy sir, this patient had a chest pain for 3 days, and he visited him. The cardiologist, Dr. Srinivas Reddy sir, identified immediately. He did the echo and identified him as a acute LV free wall rupture, and immediately mobilized to our center. At the time of presentation, patient was having almost no pulses, only carotid pulse was palpable. He was in a cardiogenic shock with a tamponade. We wheeled him immediately, got CAG done, and we found the culprit vessel was a huge diagonal artery which was blocked 100%. In the same night, we took him for surgery for the repair of the LV rent. We have only one echo image which is showing there is a gap in the left ventricle. This was the rent area. We put him on a fem-fem bypass, opened the sternum. We found that there is huge hematoma and active bleed was there in this area. And it was not easy to suture that rent. It was because very friable tissue. We opted a very innovative mechanism. We used cryoglobin glue and put repaired with a PTFE patch. This is a new innovative sutureless closure, and after clearing the hematoma, the rent was compressed and this patch was placed and adhered with the glue. 3 months after this surgery, we got his MRI done, and the patch is well incorporated, thickness is preserved, and is doing well. Another entity of delayed myocardial infarction who present as a surgical case is a ventricular septal rupture. One of our patient, she presented with arthropneic condition. If you see the monitor, she is having tachycardia, heart rate is 138, desaturated patient, and we diagnosed her as a ventricular septal rupture. When we took her for emergency surgery, this was the anterior apical rupture. You can see here the huge rent in the intervenous septum near apex, and entire is whitish area as the infarcted area. This rent we repaired with the patch. We used dual patch with a dacron and bovine pericardium.
and eventually closed the left ventriculotomy. This is the post-operative echo, where this is a patch here which is intact and there is no residual VR in this case. And she was discharged on day 11 and doing well. Another scenario of ventricular septal rupture, which is more complicated than apical VSRs, is infero-posterior VSRs. This is just a surgical video I am showing. This is, we have opened the left ventricle in infero-posterior area. This is. We have put the patient on pump. You can see multiple rents here, which I am counting. And entire this area is infarcted. This patient received patch repair with the dual patch technique. And this was the patch used with the buoyant pericardium and diaphragm patch. And we eventually closed the ventriculotomy and shifted with the inotrope and IBP support. And eventually got discharged on day 9. VSR cases are very challenging because as a surgeon, we need, whenever we took the sutures, sometimes they won't withhold because of friability of the cardiac muscle. Invariably, they present with biventricular dysfunction, and multi-organ dysfunction syndrome is common. At our hospital, we have operated 8 cases in last 2 years, out of which Becker's type 1, that is the infero-posterior VSRs, we have 5 cases, all were infero-posterior type 1. Becker's type 2, we had 1 case having anterior-apical VSR, and Becker's type 3 VSR, 2 cases, 1 anterior-apical and 1 infero-posterior. We had only 1 mortality. She had a neurological injury, and this was the only case we had a mortality, and 7 patients, they are all doing well. In such cases, we need to have a mechanical support as we are having IVP, ECMO and all. Another entity, what I was saying is the complication following myocardial infarction. Sometimes patient present with akinesia, dyskinesia, aneurysm. I am showing 2-3 cases of LV aneurysm, how we have managed. This coronary artery disease LV aneurysm, all these patients require LV aneurysm repair and CAD. And these repairs sometimes we do on pump with the beating and sometimes the arrested heart. I am just showing intraoperative video where as a surgeon, how do I assess the heart during LV aneurysm repair or sometimes LV remodeling surgeries. This is our OT, and we have opened the chest, heart is in fibrillating mode, and we are checking the left ventricle after opening the aneurysm segment. It was anterior wall aneurysm. I have just defibrillated because the heart was fibrillating. And we continued with CPB supplying the coronary perfusion. On beating, we assessed the contractility of LV, which part is contracting, which is not contracting. We are measuring, palpating the thickness of LV, where to put the sutures, how to reduce the size also. So once we assess, we repair it with a patch technique. There are many methods of doing LV aneurysm repairs. This patient before surgery has a CTR ratio of 18, and after surgery, the size has reduced. Another case who presented with the LV apical aneurysm, echo is showing huge LV apical aneurysm. We opened, in this case, took him for surgery. We opened the apex, removed all the clot. I'll just skip this. Did LV aneurysm, apical aneurysm surgery. This was the eventual result. We closed the aneurysm part with a Dacron patch, and this is the end result of the center. This patient was eventually discharged on day 6, is doing well. So day 9, doing well. Another case, patient who presented with only recurrent VT, and he was taken for a coronary angiogram. In angiogram, in echo we suspected some mass behind LV, we couldn't identify. We did LV angiogram, and we saw that there is a posterior, you can see here, where my cursor is there, huge like tennis balls like structure, which was posterior wall aneurysm. We took him for emergency surgery, opened the aneurysm and repaired the Dacron patch. He was discharged on day 7, still doing well. The last entity which I want to tell is delayed presentation after sometimes 3 months, 6 months, 1 year or few years following myocardial infarction. Some patients they come with big heart with a cardiac segment. Sometimes we offer them a LV remodeling surgeries. What I am saying is this: they present with the CAD with good myocardium here, but some of the myocardium is gone, muscle is gone, and this is entire lower kinetic segment. As a surgeon, can we do only CVG in these cases? Yes, we can do, but sometimes they don't do well. If I offer them LV remodeling surgery, these are the candidates following CVG with LV remodeling surgery. They have a longer life and the quality of life is good, and NABH Accreditation class will be much lesser. What I am showing in this pictorial diagram is, if any patient who comes here with this left ventricle, with this gray area is a kinetic segment, by surgically if I seclude this segment and keep entire alive tissue in the left ventricle, this LV will act much better. Of course, we have to maintain the geometry of this left ventricle. And if I do only CVG in this setup, the longevity, the symptomatics, everything will be different. If I provide this only viable area, it will be different. We have operated a good number of cases as a LV remodeling surgeries. One of our case has a triple vessel disease. We did, this was the angio, left ventricular angio showing only basal area. Here it is contracting, here it is contracting. From interior apex and the apico-inferior area is not at all contracting. We did LV restoration surgery. I'll skip this video, I'll show the echo only directly. See, this was the post-operative echo. This left side is pre-operative. LV is showing globular LV from here to here. If you see my cursor, it is not contracting. Soon after surgery, the right side, most of the LV wall is recruited. If I would have sent him with the CVG with this globular heart, naturally would have come again and again. Now I have given him better heart, which is smaller size, normal geometry with recruitment of all LV. Same patient, following 2 days later, we did, this is not TE, transthoracic echo. We found that most of the LV is recruited well. So we have given him a good viable left ventricle. We have taken out akinetic segment. We did LV restoration surgery and he is doing well. He was discharged on day 10. All these cases, akinetic segments, dilated hearts, if we do CVG, they require longer hospitalization. They remain symptomatic with having low quality of life. If we, as a surgeon, add other armamentum like LV remodeling surgery, mitral repair or anything, we can give them better longevity and good quality of life. The take-home message is, most of the complications after MI, they usually present delayed to us because of multiple factors. Early angio and reperfusion, we can prevent most of the things. High degree of suspicion in such cases required, especially they have prolonged pain or ST elevation, or high and rising trop eyes, rising CRPs. Even the top eye is reducing, but CRP is rising is also not good. Early intervention are beneficial. There are few exception cases. Thank you.
Sir, any inputs from Lokesh sir, sir?
Sir, I have one question. What about moderate MR? In the presence of moderate MR, triple vessel disease patient undergoing for CABG surgery, how we should be careful? Because sometimes after CABG, that MR becomes severe, then again he may has to go for redo surgery. So what are the precautions we will be addressing prior to the surgery?
In patients with multi-vessel coronary artery disease and having moderate ischemic MR, usually we go by the jet area and the pre-contact. If it's more than 5 centimeters square, we have to go for do the mitral valve repair, because most of these patients respond well. But to have a randomized study on this type of patients, the RHYMES trial was there, which was abandoned due to technical difficulty of conducting it. By knowing the benefits of repairing the moderate MR early in life than later on. So I think any amount of ischemic MR significant, so it has to be repaired, because post-operative MR, persistent MR would prolong the post-operative course, and anyway in due course they will come for the reoperation by doing the mitral repair at that point of time. Unless if the patient has got a mild or low moderate MR, where it is directly related to the ischemia of the papillary muscles, in those patients only after revascularization the MR lessens. So that's why intraoperative TEE after completion of revascularization, would help in deciding whether we have to correct that MR or not. Thank you.
Thank you, sir. I call upon Dr. Ramesh Babu, sir, for giving the memento for the